10 months into this pandemic, and we have learned a lot about COVID-19. The virus is especially cruel to communities of color, with African Americans and Latinos experiencing much higher rates of infection and hospitalization. To talk about the longstanding health and social inequities that have played a role in all of this, I'm pleased to introduce you to Dr. Rajneet S. Lamba. He is an internal medicine hospitalist and is currently serving as president of the board for King County Medical Society. Dr. Lamba was born and raised in King County. His parents are both involved in the practice of medicine, and his mother has been a dues-paying member of the King County Medical Society for over 20 years. He has the privilege of working in the same practice setting as his younger brother, Dr. Amrit Lamba, who is a new member to KCMS this year. Dr. Lamba is honored to be advancing the interests of health equity with the King County Medical Society today. And I'm also happy to introduce his special guest and co-presenter, State Senator Manka Dhingra. She represents the 45th Legislative District east of Seattle. And here's a really cool fact. She made history by becoming the first Sikh elected to any state legislature in the US. Welcome to both of you.
Thanks, Ursula. I'll just start by mentioning the senator. I'm in the 45th district, so it's an honor to be here with her today. So she's representing my district. She flipped the Senate at the state level in 2017. She's a deputy majority leader there, practicing attorney. I guess as a nimble medical society, it's nice that we've included her and added her to bring health policy into this.
It is such a pleasure to be here. Thank you so much for that great introduction. And it really is an honor to present with you.
Thanks. And I'm still not sure, I'm not getting my video, but I can certainly talk through this. So here's some key topics we want to go after: racism and discrimination, COVID-19 associated inequities. Happy to have the senator here to bring in health policy and advocacy this year. See if we have any insights on vaccine allocation, but an important topic here: social and political determinants of health. There's an interesting NEJM writing this year, and that was stolen breaths. And that was speaking to, unarmed Black people that were dying from police violence. And there was an interesting comment in there that all policy is health policy. And I think that's really something important this year, especially. So I guess I'm an Asian American. I'm the second Asian American president for the King County Medical Society. Freddie Chen, you heard from earlier. This is just some commentary I picked up this last few weeks, just telling my colleagues and friends in my network that I'd be presenting on racism in medicine. So I think just talking about that, physician lounge, friends, Facebook, social media, this is sort of the comments that I got from Asian American physicians. The last one's notable. I think that's a patient was calling into the clinic. And so if they hear a name that sounds foreign, they'll often say, does this doctor speak English? And so they're working within an organization that serves English speaking patients. You would probably presume that they do, but they're asking these questions. And this one was a comment saying, well, okay, as long as they're not Black. So again, just anti-Black racism is sort of its own thing in the United States. So this is, I think, a big part of how we had this, why we're having this conversation today, both in the CME and in Seattle and King County. So this group, I was so happy that they were able to work with us, and they'll be in our Q&A. So Dr. Estelle Williams, Professor Edwin Lindo, I think I see Dr. Quiroga in the background there also. They were all speaking. This was picked up by the British Medical Journal. This has, I posted up their requests and demands for the March. Again, these are policy changes addressing these issues.
I just want to quickly comment on the Asian experience. And while we're talking about that in the healthcare field, I'll just say it is very hard as a person of color to even run for office. And so that Asian experience, it's not just about healthcare and COVID and having that same last name. It permeates all aspects of our lives everywhere.
Thanks. And so I'll go to the next slide, which is actually related as well. So this is this was our KCMS response. So we had been messaging about COVID all year. We had been advocating for telehealth. We had a fundraiser. We raised $400,000 to get frontline PPE. And then, this really got pushed into the front of our minds. George Floyd, Breonna Taylor, Ahmaud Arbery, as the president of the organization, planning out the newsletter, talking with Michelle Terry and Nancy Belcher about these things. Amish kind of stepped up because we said we need to comment on this, and I think everyone's feeling exhausted. And if point number 2 here is the AMA was mentioning that they were speaking out on legal intervention deaths, is how they stated it, officer homicides, public health perspective. So that's been a key this year in Seattle and across the nation. And then that has kind of led to these conversations about racism, acknowledgement of issues in the United States, Washington State, King County, and Seattle. I thought this was a really well-worded statement on short notice in June for our medical society.
I'll just take it one step further and really say that when you talk about racism and you mentioned about all of this being a healthcare issue, the bottom line in America really is that the darker your skin color, the harder life is for you. And you know that from the time a woman is pregnant, right? Her access to healthcare is an issue of her skin color. When babies are born, the care that they get, and maternal mortality, from access to education, to housing, to employment, and now to access to healthcare, and taking a look at police brutality. So it really is, I think people have to understand and acknowledge that that is a true fact in America, that the color of your skin is something that determines the quality and kind of life you're going to have.
Thank you. And so I just was going to share this about my, sort of personal experiences with discrimination. I actually, thinking back, I wrote about this in my college essay, but, I'm a Sikh in America. So we're 0.15% of the population, 1.7% of the Indian population. So, my father wears a turban. I was a person who was, raised initially looking to wear a turban. This is a jura. So this is kind of what a child would wear until they're an adult and wearing a turban. So I made a conscious decision, I guess, in the second grade, due to discrimination, sort of getting in fights at school. Our school counselor said maybe you should just, if he cuts his hair, it might be easier. And so my parents both, with a strong focus on education, said, that's going to be the route we take. My name is on the slide also, so I'm just going to mention that. After getting my education, R3 resident, Cedar Sinai in Los Angeles, completing all of that work, I was interviewing for positions as a physician in King County, Pierce County, and I was asked mid-interview by the interviewer, I should let you know that we don't do work visas here, and so that was kind of off-putting. They hadn't really read my resume to understand what my background was, that I'm born in the United States, I'm a citizen. It's not a concern for me, but it was a very othering statement. They tried to back away from that by they ended up doubling down by saying, I saw your name and that's why I said that. And so, it just sort of disrupts the process, and it reminds you that, even just your name is enough on a resume to say, if someone didn't read carefully, they're going to make a lot of assumptions about you.
So I want to thank you for sharing that story, because this is actually one of the reasons I ran for office. As you mentioned, I've been a senior deputy prosecuting attorney with King County for 19 years and never really seriously thought about running for office. And I wanted to get politically involved after our national election in 2016. And a few things happened then. I'd actually been involved in working on hate crimes after 9/11, when a Sikh taxi driver was assaulted in Seattle. And so I've done a lot of cultural sensitivity training for law enforcement around Sikh culture. And in December 2016, the local mosque in Redmond, MAPS, actually had a huge safety forum. And I had gone there, 6 of our local police chiefs were there. And this was a large room packed with people. And I sat there and I heard people talk about how scared they were. They didn't know whether they should buy a house. They didn't know if they should buy a car. And there's some people who didn't know if they would be allowed to live in this country. And a few days after that, I was at a hate crime seminar with the Indian Association of Western Washington in Bellevue. And it was the same thing again. I was there, we had someone from the FBI, and we had an assistant US attorney doing a seminar on hate crimes. And I had Indians from Woodinville, Sammamish, Kirkland tell me that their children had been told that they're going to get deported now. And it really was that weekend when my husband and I and my family talked and we decided I was going to run for office, because it's so crucial for our democracy that all of us are represented. And it's so crucial that different voices are at the table, because only with a diversity of thought are we going to have policies that are better, that are more inclusive, and work for every single person in our community.
So yeah, I've really been thinking about those things a lot. I'm going to push through these slides a little bit and then let the senator comment, because I just want to quickly speak to just my experience as a Sikh, and I know she may have something to add to that too. So as I mentioned, religious minorities, equality amongst all is kind of a big founding principle. Denouncement of the caste system in India and traditional gender roles. So gender equality is very big here. And if we're denouncing the caste system in India, I think it gives us all an insight into denouncing the racial caste system in the United States, as you mentioned, about different colors. Next slide. So guiding concepts here, a lot of it is based on community service, selfless service, again, equality and freedom of conscience. I think as a physician, I really respect patient autonomy and patient decision-making. This is Bangla Sahib in New Delhi. This is a Gurdwara. So this is just social justice movements. They resonate with Sikhs. So June 16th, I think, is a date that a lot of African Americans have been talking about. This is 1606. So this is around the time of the Mayflower. This is around the time of the first slave ships coming to the Americas. Is kind of a formative time in our religion. And these are people who basically, they stood up for what they believed in. They were willing to sacrifice anything. They were willing to stand up for other people, which is another key tenet. And so then this is the last point is about how kind of the Khalsa is maybe what a Sikh would look like to you, with the turban, with a beard, certain articles of faith. And that's in the next slide. Go ahead. And so, so this is kind of a martially trained Sikh he's sort of trained to protect himself and others. And so here's a slide I guess I got from the Senate. I'm glad we've been talking about these things. We had a pre-call. This is top 5 policy issues. So in the way this survey, just to give you context, there's a list of 17 mostly progressive topics, and people said, what are your top 5? So you'll see DV, domestic violence, and LGBTQ low, but that just means they weren't picked in the top 5 out of this group. So I know Senator Dhingra's done speaking on this, so I'll let her jump in and add anything.
Yeah, it's really interesting because until I got involved in running for office, I hadn't really critically thought about my life experiences and my background making me who I am. And what running for office really makes you do is really think a lot about why you're doing the things you're doing, because people ask and you have to explain it. And I don't particularly come from a very religious background. My husband's a Sikh, and my son had his hair until we decided that he should cut it in 8th grade for similar reasons as what Dr. Lamba was saying. But when I really think about, what drives me and what has driven my family, it really is about the tenets of seva, right? Service for the community. And I can go back to my grandmother, her and his sisters actually worked in refugee camps in India, providing help to everyone who came in. It goes to this concept of equality. And I have stories upon stories of my grandmothers, insisting on riding a motorcycle when no one else was in this tiny village in India. She was the first woman on wheels. And it really permeates through a lot of what I do. And, it goes back again to my point, is that you got to have different people with different backgrounds and different views at the decision-making table, because our backgrounds do impact who we are, the manner in which we think, and our value system. And so it isn't enough to say that the same people at the decision-making table will make great decisions, because they simply don't wear those different hats. And I say that about women too. Women wear a lot more hats than men do. And when you're a woman of color, that's a lot of things you're responsible for. And, when I talk about being the senator from the 45th legislative district, I can tell you that my office receives way more emails and phone calls than any other senator in Washington, because every Indian in Washington thinks I'm their senator. And I'm honored and privileged that they do. Women of color all over the state think I'm their senator because I'm available and I create that access. And so it is different. Leadership looks different and representation looks different.
So I'll go to the next slide, and this is the women. My wife chose this slide, so she got this from Instagram. This is actually interesting. So again, the priorities here are pretty similar, and I think this way you can kind of see that all these things are relevant. All these social justice issues are relevant. Speaking to the protest, this is related to a protest that's actually happening right now. 250 million, again, 250 million Indians are on strike in India related to income inequality, radical neoliberalism reshaping the country. What are the priorities for the country in the setting of coronavirus? There's 300,000 Sikhs that are farmers that are subject to state violence. We're talking about water cannons and tear gas. And so in some ways, it feels related to this, what's happening in America, but it also talks to social and political determinants of health. And we'll be going there just right after this. Going right into coronavirus now, I don't have a picture of a viral particle, but we've been talking about this since about February 28th when the outbreak was diagnosed at Evergreen. So I think early, crisis standards of care, a lot of crisis in King County. I think our area was a few weeks of other major outbreaks. CDC was issuing guidelines specific to our county. So again, we're messaging a lot of things about this. We're talking about disaster management, crisis standards of care, triage. There was a committee in the state related to that. So one of our board members here, Daniel Lowe, he's been writing about equity all year. He's a great writer. He's been leading us into Seattle Times, Crosscut, South Seattle Emerald. But he had a great just viewpoint on equity. And I think he had this article in March. So while everybody was scrambling, he was looking at this data across the country and published this and helped focus our board on these kinds of priorities early. And now you're seeing the national conversation after George Floyd, after other things have made that more visible, after the numbers have borne out the concerns that people have had in this community. He'll be working with Health Point Clinic, and he just graduated his residency. Great to have him on the team. And the next slide, we'll start getting into some of the data. So I want to say this is from August. When we're looking at data, we're looking at different populations. It sort of depends on how you construct your data. What are your social descriptions of race and how are you breaking things down? I circled here that race and ethnicity, the CDC is describing as risk markers for underlying conditions that impact health. This will be an interesting one. I think if people want to get at it in our question and answer, because again, we have so many experts there. But so it's nice that they're saying that race is not the problem. And they're saying these are some of the social and political determinants of health. But also, maybe there could be some criticisms that they haven't said racism. And there have been criticisms of the CDC and their organizational structure from former employees. I think hundreds of former employees have talked about limiting science into race, scientific studies and additional discussions of race at the national level through the CDC. But here's some numbers. And if we go to the next slide, this is some of the early stuff. This is September. Why do we think we have disparate outcomes? I think a lot of this was related to testing is what they were seeing, or they're just showing that high positivity rates with the tests from people of color. This is national data from Kaiser. They looked through all their EPIC records. Some interesting things here are that, so they're saying high positivity rates, people are being diagnosed in the hospital instead of the community. So it speaks to access to testing. They're actually saying when you factor out socio-demographic factors, you notice that Asian patients even are actually still pretty high risk. I think of things like, okay, political determinants of health. So we talk about voting inequities. There's one drop box in all of Harris County, Texas for 4 million people. And it makes you think about how are we allocating resources and testing and how do you get that? I think you're involved with minority access to care. So you may have some comments.
Okay. The one other comment I would like to make on data and statistics, and I love being data driven. I love taking a look at the numbers, but you also have to figure out, what do those numbers mean? Who's collecting that data? And I actually had seen coronavirus statistics that excluded nursing homes. And if you exclude nursing homes and then take a look at the racial disparities, it is even more striking. And what they found is nursing homes actually tend to be overwhelmingly white, the people who got coronavirus. And so if you exclude that, it really gives you a very different picture of what is going out in the community and who's getting coronavirus. So, it is really important that we take a look at this data. And some of the things that our state has been doing is our Department of Health actually does look at racial disparities and has done a lot of work around taking a look at healthcare delivery systems in relationship to to race. And one of the things that they were involved in a couple of years ago was actually looking at creating a statewide Office of Equity. This is something, it was my bill in the Senate last year. And so we were the first state to have a statewide Office of Equity. And the timing on there was actually critical because a lot of it is about how do you deliver services. So it is really about understanding the institutional and historic racism that has existed in our country. And that even acknowledging that many times the policies and processes we have are an outgrowth of that. And so this office is really tasked with taking a look in the manner in which services are delivered from agencies and really take a look at even the makeup of those agencies, who's delivering the services in what manner. And so right now, during this pandemic, we're actually trying to hire an executive director during this time. And the things that we really want this office to do is take a look at the manner in which race has been impacted by the pandemic. Also take a look at distribution of vaccines when they become available to make sure that we are able to permeate into different racial groups, regardless of socioeconomic stature, regardless of education. And part of that also has been really all the work we've been doing around making small businesses, business loans available. The first time that happened at the federal government and the state level, it was on a first come, first based. And let me tell you, when you have it first come, first served, it's not the minority or the women-owned businesses that are getting the grants. And in Washington, me, Senator Vandana Slatter, who's also Indian, Claudia Balducci, we had an East Side small business minority group meeting every 2 weeks. And we were able to change those rules in the state of Washington. So the next time we had grants go out, it was not first come, first served. We made sure that we were working with credible messengers within each community to get the word out, making sure we had language access for people and help in actually filling out paperwork. Because when you say, oh yeah, let's translate that document into another language, you cannot do a word for word translation. It has to be a culturally appropriate translation. So you're actually communicating what you need to communicate, not simply using the English words and using the other language words in replacement, because it doesn't always make sense. So I'm actually very excited about what having the first ever statewide Office of Equity means for our state. And I just hope you guys pay attention and help provide any guidance or information moving forward, especially when we take a look at access to healthcare for different communities.
Yeah, I think you said first statewide office of that. I also have to thank you for the first statewide firearm safety. I know that was something that we worked on together, and that was probably our big public health issue heading into this. Actually, at Evergreen, we had a active shooter alert. It was the night before that we diagnosed this. So it was like boom, boom, boom. These things were back to back. I think someone was testifying in Olympia with you at that time in February. So next slide. So here's, this is APM Research Lab. They update weekly. So this is an interesting place to find some data. I think the indigenous numbers I prepared this last month, and now the indigenous numbers have passed the numbers for Black people. I'm even putting a comment on this slide because this is taken from their website, the language. Initially it says up front, other racial groups, and then it goes and goes and goes, and then it says compared to white Americans. So it's fair to compare, but even just the way that language is, I don't think that's ideal. But this is some national data. And I think our state, if you go to the next slide, is quite similar. This is another way of putting the language. And so again, speaking to the indigenous, I'm recalling, I think there were local tribes looking for help and asking for PPE, and I remember that body bags were sent out accidentally by the federal government, and that was sort of a
Mhm.
sign that people picked up on. It was very ominous, very dark. So this is the state data. It doesn't have the the multiplier to make it as easy to look at, but so again, we're breaking things down here as Native Hawaiian and other Pacific Islanders have very high rates. The indigenous and represented by American Indian and Alaskan Native, and then Black people here as well. So I think it's also interesting, like you said, when we look at the data, what is indigenous? How are we breaking that down? Washington State is trying to be a little more specific there. I know, for example, institutions are starting to look at this. They're wondering if hospitals and payments are going to be looking at outcomes data by race. Eastside Health Network is starting to look into this, and they're doing it very specifically and precisely because I think it's self-reported. So I saw some early look at some numbers, and they specifically had Punjabi there, I noticed, and they're going very detailed rather than Asian, which is very broad. So here's some more numbers. So we'll just move on to the next slide. And so I think this is some of the thought, okay, well, why are we seeing these outcomes? I think that's what everyone's been interested in debating. It's nice that we've had speakers address a lot of these issues. We're looking at cancer, diabetes, cardiovascular disease, including chronic kidney disease today. So we'll see that certain populations have more of this, so underlying health conditions. Sickle cell disease is on this list, and that's an interesting one that people have been talking about and debating. Is it a race-based disease? I think people are saying this is a geographic disease. It's not, in our country, it's associated with Black Americans, but it can be white people, it can be Arab people that are adapting to that climate. So it's more related to geography than the melanin itself. Next slide. And so here's another comment, I guess, towards scientific and biological racism. Professor Lindo, I believe, was commenting on this. Studies that were being done to prove differences in race, people's skulls being different sizes. He mentioned how Nazis were learning from America about this. This is actually a Nazi physician with a Nepalese person to study. So this was an attempt. I think this is going to be printed in March, and it's received some criticism. This study in JAMA talking about differences in receptors within the nose. I messaged Dr. Nyawe about this because he has the urological input. And so if you notice, it says TMPRSS2 expression differences in prostate cancer are different. So I asked him, he said, that's very inconsistent. And so I would find this data to probably be very inconsistent. We're talking about 305 patients, 50% of these patients have asthma. This is a small segment of New York City. I don't really think they should be expanding studies on this, but this is an attempt to try to explain the differences and maybe looking into therapeutics. So this is probably a bigger factor, social determinants of health. So this is things we've been talking about. Doctors are all trying to look out. It's a great place to involve our legislators. So economic stability, education, social and community context, health and healthcare, neighborhood, and built environment. So I have a lot of slides with data, but really I'm opening this up so that Senator Dhingra can tell us more.
So I'll just add that one of the things that I've been involved in the last couple of years is the governor's poverty reduction task force. And I, for one, am not necessarily a huge fan of sitting on a lot of different task forces. I prefer to make sure that we're actually engaging in action. But it is really important to make sure you understand what that action should be and have thought through that. And so this poverty reduction task force actually has been a really amazing experience because it really started taking a look at why we see poverty in America. And a lot of this goes back to really understanding intergenerational poverty, understanding historic trauma, and really understanding the policies we've had in this country that go back to slavery and how that's impacting people today. So a lot of what the poverty reduction group has been talking about is really trying to get to understanding how we even talk about poverty, right? We have what we call welfare programs, right? We want to help people when they are struggling and you want to assist them. But we don't really talk about, are these programs, is this assistance actually creating a path for people to exit poverty? And so that's what we're trying to do in the state of Washington now, and I'll have a bill on this next session, is really redoing the manner in which we think that government or the state provides resources to people, right? We make sure we provide them access to childcare, but the minute they get that raise, we get rid of that. And so that raise actually puts them back into poverty. Because they no longer have access to the resources they need for childcare, which we all know is so expensive. So really taking a look at, as a state, are we really thinking about wealth accumulation? If someone is receiving services, let's make sure we have a plan for them to exit poverty and a plan for them to accumulate wealth. I will say this summer, we had actually a really great bipartisan social experiment on what happens with direct cash benefits. And what did we find? We found that when you actually give direct cash benefits to people, individuals get help, families get help, and the economy is helped. And so it really is about thinking differently about what people need and how you make them successful and how actually helping individuals helps our economy thrive.
Yeah, and thank you for that. So let's go to the next slide here. So here's just another thing about sort of exposure. So when we're talking about social determinants of the virus, this is from South Seattle College. And so this is local data, racial minorities being essential workers. I think this is things we're going to be thinking about when we're doing vaccine distribution. We're in phase 1 right now. We're looking at healthcare workers that are high risk, and we're looking at nursing homes. But these are all areas that we'll be looking soon. And one thing that was interesting about this data, we're talking about high hazard, low reward. So there are people that they can't really say no to this job. Most likely they need this job, they need to show up to this job. They may not have the right to advocate in their workplace very strongly, and we see the data and the disparities and inequities there, which groups are on the front lines there, and that'll come in vaccine strategies as well. Next slide.
And I would just like to challenge all of you. I think about 2 years ago, if you had said, make me a list of the top 5 essential workers, those are not the people you would have on your list. And someone recently testified in Olympia, and she said, you know, the year 2020 has given us perfect vision. We have clearly been able to see the inequities that exist in our society, all the way from, again, housing, education, access to the internet, to healthcare. And so I really, that last slide, I just really want you to think and challenge your viewpoint on who you think is essential in our lives.
Yeah, and even in the hospital, I think, you know, physicians, we think of ourselves and all the great work we're doing, but then we have to think, okay, well, the nurses are spending more time in the room with the patient. The cleaning staff is adjusting to these new protocols, and they were turning over rooms so rapidly in the beginning of this outbreak. So I'll move quickly through these, and you can pick up anything you like, though. So this is just disparities. This is not brand new data, but this is what I was able to find was things related to the ACA, and they were showing coverage improvements across races, especially for minority races. And so, you know, the states, there's a lot of data that states that have implemented things like this have this sort of an anti-racist policy, because you're disproportionately helping people of color by insuring people. And I know there's a lot of work being done to try to improve insurance access, and there were a lot of concerns about losing the ACA as the current model. And should we be going towards Medicare for all? And that's probably a big conversation. So I'll just go to the next one. And I just have a little bit about median household incomes, because you're mentioning generational issues here. So this is the data for King County, and you can see that it's pretty easy to see visually. And next slide. So this is median net worth, which is speaking to this as well. So there's came across this term, the racial wealth gap. So just how much people have and how much security they have. You know, what can you tolerate if you get sick? I think Dr. Nyawa mentioned that as well. You know, it's more precarious for some populations of people in Seattle. And then the next one is redlining,
Mhm.
which Professor Lindo mentioned. He mentioned this was in the 40s. This map is from the 40s, but was continuing into the 70s. And you may have some comments here. I just wanted to get us to this point as a good visual to kind of talk about generational issues.
And this is where I think people really need to make sure they acknowledge our history, right? Why is it that certain sectors of our population were able to buy those homes? Because loans were made available to them. Why were they able to move to the suburbs and others weren't? And so a lot of those decisions on who gets loans, who gets to move, who gets to accumulate wealth, one of the things that people are able to give to their children is that family home. And it goes back to the slide you saw before this on that wealth gap. And a lot of that is tied directly to policies that were made by your elected officials. And so we now have to make sure we are undoing those. But the accumulated consequences of those policies is what we're dealing with as the racial inequities. You know, you hear people just make racial assumptions about those people and why those people aren't rich, but they aren't because they have not been given that opportunity to generate wealth like other groups have been able to do so. You know, my husband and I had a lot of conversations about the Black Lives Matter, and you know, both of us clearly understand that if it wasn't for the civil rights movement, a lot of us Indians won't be here. It's because of what the civil rights movement, Black Americans did in America, that it has allowed for immigration for, you know, us Indian Americans who are the so-called model minorities, right? The stereotype is that we're engineers and doctors and you know, the affluent individuals. And you know, Dr. Lamba's family definitely is a prime example of that, you know, a medical family, and the rest of my family is comprised of doctors and engineers. But we are here because of the sacrifices that other people made. And that's the unfortunate truth, is that there isn't a mechanism for making up for that lost time for the Black Americans, for the indigenous population, for the Hispanic population that has been here for so long.
Yeah, that's a great point. You know, our presence here and our influence here is related to struggles with civil rights, changes in immigration policy in the 60s. You know, so our contribution to society is also tied to that, and xenophobia is sort of a brain drain or reverse brain drain, I think of it as. And so a specific word I wanted to mention also was sundown town. So you're mentioning here the different areas, but I think this was going also into the 70s, that if you're in certain neighborhoods north of Madison, is what Professor Lindo said. I think north of the Ship Canal Bridge, there's towns up, neighborhoods there where if you were Black, you could come and you could work, but you would have to leave by sundown, or you could be arrested or jailed or harassed. And that's an interesting term. And there's a lot to read about for people. There's a resource here. Next slide. And also you mentioned the political determinants of health also. So the resources there that go up to the legislative level. This is also environmental health disparities. This is DOH. So we see that there's a large smelting plant that's affecting South Seattle and downtown a bit. And then further south, there's additional pollution from, you know, issues with the Duwamish River. There's a fund going on from King County Public Health. It's called Fund to Catch Toxic to Eat. So they're educating people that you can't eat certain fish in that area. And there's just so many effects of environmental injustice. And I'll go to the next slide. I think there's a lot to talk about on that issue too. And then this also is just something I threw in about, you know, when we make policies, when we're trying to correct past unjust policies, it's hard because we often end up thinking about our own priorities. And so, you know, we voted against affirmative action. The legislation's tried to pass that. Desegregating schools in Seattle went all the way to the Supreme Court, and people are worried the Supreme Court is moving right. What are we going to do? But even in 2007, we couldn't pass these things to desegregate our schools by affecting the school choice process.
I'll just add on this, when Initiative 1000 was sent to the legislature, in the beginning, a lot of legislators were like, we're not dealing with this. This is something that the people of the state of Washington need to deal with. And so if the legislature doesn't approve it, it goes automatically to people. And I can tell you that the members of Color Caucus, right, that's what we call ourselves, and we fought for this. We really made sure that our white colleagues understood why this was so needed. For the first time, we had 3 of our ex-Washingtonian governors. All 3 of them came to Olympia together and testified and said, we need this. We need the legislature to approve this. We had tech companies, institutions of higher ed, everyone come in and say, we need Initiative 1000. The number, it does not make sense for us to not have this policy, because we have seen how negatively it is impacting people of color. And it was a huge fight, and we passed it in the legislature. And I, in my optimism, thought, okay, now we can convince everyone else in Washington why this is so crucial, because the data tells you it is. And unfortunately, it's many times the easy negative slogans that win out over data. We see that over and over again. And this was one of those measures. And I really do feel terrible about it, because this wasn't a data-driven decision at all. So I'm hoping there are things we can do, but at this point in time, I think it's up to individual institutions and individuals. And I think 2020, hopefully, really makes people stand up and take responsibility and say, yes, I personally, in my personal life, I'm going to be anti-racist. And I'm going to make sure that my children and my friends know what that means. And so even though this did not make it through the ballot system, I challenge everyone, if you're here today, to openly acknowledge that you are going to be anti-racist and do this work. Because I think if everyone steps up and takes responsibility, we can get there.
Yeah, and affirmative action is such a loaded term, but there's these structural issues we're talking about. There's also, bias when Black interviewees go for medical school interviews and the kinds of questions they're asked. I've been reading some of these things. And the comment that I made earlier where someone said they wouldn't see a Black physician because they may feel like this person got in through affirmative action and all this bias. But I mean, I think there's many qualified candidates. It's not really a problem of that. There's other factors here. We have our scholarship fund. So that's what this point. And now I have a couple slides on vaccines, so I'm just going to push those fast and then let you close. So here's this is the National Academy of Medicine. They had a framework here. They called out that there's these disproportionately affected groups. They want to mitigate these factors rather than maybe applying racial and ethnic categories to prioritize vaccines. They may use this social vulnerability index. So next slide. All this is happening at the state level, state decision making. So this is phase 1 through 4. This is from the CDC. I mentioned the people that are in phase 1, phase 2 is going to be following. All these have to get broken up within the state. So, you can look at all these people in these groups, but you also have to break that up and specifically allocate. I'm hearing something new that King County Medical Society may be involved in some of this as well. So this is exciting. Next slide. So this is social vulnerability index. It's used for catastrophes like hurricanes, Hurricane Katrina. It does include minority status, so that's very interesting. There's questions on the legality of this, but this is vetted through the CDC and they use this already. Next slide. And we're looking at social and political determinants of health. This is the state. So this is broken down by county and it's also broken down by census tract. So it's a pretty large group where comparing to the next slide is the ADI, which was mentioned by Dr. Vassal. This is also social determinants of health, does not specifically mention race. And the next slide shows you kind of the population levels involved. It's much more specific. it may be helpful. So even though it's not race-based, it may actually help racial minorities because it may actually target their neighborhoods based off of these issues. And then the last thing to say on the next slide is going back to kind of the ACA and policy decisions is, if you look at, well, states, how are they going to implement this? These states that did not implement the ACA, almost 50% of American working age Black Americans are in those few states. And so they really got shut out of free healthcare dollars, federal healthcare dollars, because their state did not implement. Again, Washington State has done the right thing on that, and I hope we do good work. I hope that people know to reach out to their legislators as this decision making is happening. Work through the medical society to reach your legislator. But I'm also worried that there's going to be really problems in some of these areas if states don't think about equity.
And, I'll just add, the state of Washington actually has been on the forefront of really embracing the concept that we need to make sure everyone in the state has access to healthcare. And I know there was a question on a public option, Cascade Care, that's up and running this year. And, the number of people we can have enrolled in healthcare, goes to everything we're talking about here. We need people to be able to access healthcare. And so I think this is something we can be proud of as a state. And, after my election, we actually flipped the Senate. And that is what actually enabled a lot of these policies to go forth. And so I think with the implementation of Cascade Care, with our public option, there's studies now there on like a roadmap of how do we make sure that we are creating a system where everyone in the state of Washington can be insured.
All right. Yeah, we went a little over, but there was a lot we covered there. So I really appreciate you joining us today. We hope to keep working with you in the future.
Thank you so much. This was a great pleasure. And please, anyone, feel free to reach out to my office anytime.
Thank you, Dr. Lamba, and thank you, Senator Dhingra. The information that you've shared, I've got to tell you, as a co-host of a radio show here in Seattle, the topics that you've discussed are topics that we discuss every single day. And it is so important to understand the historical background to be able to talk about it. And you've helped so much. And I want to just thank you personally, Senator, for the work that you are doing in Olympia on behalf of so many of us. We really appreciate your efforts.